Now, I'm going to give you a bit of ideas and information about what is going on in Ontario, because this is where I'm practicing right now. And telepsychiatry, obviously, I'm going to talk about it in a minute. First of all, I would ask you, who did not practice telepsychiatry? By any chance, can you raise your hand? So everybody practice telepsychiatry, which is a good thing, by the way. This is my daily work. So I'm practicing telepsychiatry almost every day. And what is telepsychiatry? Obviously, it's the application of telemedicine into psychiatry. And psychiatry can be quite useful for being in teleconsultation. Why? Because it's based on conversation and observational skills, and it provides a reasonable alternative to an office visit for patients who cannot access care. And telepsychiatry, there are different ways, and we talked extensively this morning about this: video conferencing, mobile devices, email messages, and social media. Now, what I think about telepsychiatry, in a certain way, for healthcare providers, for psychiatrists like us, I think we are in the same stage as when we started about 70 years ago with antipsychotic medication. So we are at the beginning of a new era where we will practice telepsychiatry regularly. So this is something which I think is like a kind of revolution in psychiatry. So why using telepsychiatry in Canada? Well, first of all, Canada is the second largest land in the world, just after Russia, or Federation of Russia. And we, in psychiatry, we travel long distance if we want to see our patients. And we are also scarce. There are not too many psychiatrists, not too many psychologists who work, and most of them work in big cities. The other important thing which is important to know is that we work with a lot of ethnic minorities, and we know that in some minorities, psychiatry, mental health is a taboo. They don't want to see a psychiatrist, definitely not. But if they, especially if psychiatrists work in psychiatric hospitals, but if we do practice by distance, it's a kind of a barrier which could be alleviated. I do work in a reserve. I do go to see Aboriginal populations, and it's also a challenge because Aboriginal population live in places far away, and sometimes it's not possible to go to see them. I can give you an example. There's one reserve when there's no road. So the only time when there's a road is a winter road for, say, December to March. But the rest of the time, if you want to see patients, you need to fly, or in my case, to take the train, because there's a railroad going there. Also, what is important to, as I say, to understand is that, again, as I said, the barriers are alleviated when you don't see the patient directly, and it's also important for this, as I say, the stigma. Telepsychiatry is not new. I presented a publication that we did published in 1986 in a small hospital that Professor Steve knows, Malartic Hospital in Northwest Quebec, where we tried at that time a two-way TV consultation. And that was in 1986, and one of the conclusions, obviously, was that the most resistant groups between patients, nurses, and psychiatrists were the psychiatrists. Sessions were enthusiastic, mainly because they said, well, the psychiatrist is in a box, in the screen, so he's not going to bite us in a certain way. The nurses were neutral. They were they were not against it and not for it. And the psychiatrists were reluctant, and we asked why. The main reason was that, well, we cannot see the patient at this time it was TV set. There was no internet in 86 or 85. We couldn't see the patient from the head to the feet. But I was also thinking that the issue about controlling, because this was in a hospital, it was not in an outpatient department. So I guess the issue of controlling when the patient is not in your office, which I think would be something important to think about. Okay, now telepsychiatry was quite accelerated by the pandemic. We couldn't see patients in our hospital, Montfort Hospital in Ottawa, from March 20 to October 21, and since then the access is restricted. Now it's free, we can see patients, but first of all, some patients say, oh, I don't want to see you, I have to pay the parking lot, I have to travel for an hour. So why we don't continue on teleconsultation? And for us, we have some kind of restriction in our head to say, well, if the patient comes and is contagious, we might get the COVID. So as I say, it was accelerating, obviously, forced to accelerate telepsychiatry. Obviously, we had to follow the stricter rules of travel by the Public Health of Canada. So that means the flights were not easy, because when I travel up north, I'm flying. So sometimes it was not easy. I even remember that March 2020, we were, I guess, 3 passengers in the flight from Toronto to Timmins or back, and there were like 2 pilots and 2 flight attendants. There were more crew than passengers. So it's very, I mean, there were very interesting times anyway. Now I'm going to talk, and this is very important to remember, the Ontario Telemedicine Network, OTN. Though it's a unique Ontario provincial telehealth system. All the doctors have to go through the OTN to do their teleconsultation, and obviously psychiatrists are not the only one. We have dermatologists, neurologists, radiologists, and so on and so forth. So we use the OTN. Why we are obliged to use the OTN is mainly for security reasons. All the messages are encrypted, so it's quite something. And what is important is now financed by the provincial government of Ontario, and so it's a free access, obviously, and it is validated. So we have this tool, which is quite useful. And sometimes I would see a patient in my office in Ottawa. The patient would be in one of the remote areas, and the therapist or the case manager would be another one. So there would be three of us at 3 different locations. So it's quite useful. Patients receive a code, and then they can get into the code and get into at a certain time, they get into the consultation. And I will tell you later the challenges and the problems we can have, but more or less it works. So the OTN, they say that their goal is simple, is to want to move healthcare forward by ensuring every Ontarian should have easy access to the best healthcare where and when they need it. So also the OTN is, as I say, it's important because Ontario is quite big, 2 times the landmass of France, and we are 15 millions. Also, what is important, OTN is in French also, because we are 800,000 French-speaking Ontarians in Ontario. So the key focus in the 1819 report of OTN is to make virtual care knowledge and information more accessible to patients and healthcare providers. Like almost everywhere, the access to care, especially to mental health care, is a big problem. I give you an example. Sometimes I see adolescents, 15, 16 years old. Why? It's because if you want to see a child psychiatrist in Ottawa, the waiting list is 2 years. 2 years. So for the family doctors, they cannot wait 2 years when they have patients who are scratching themselves, you know, suicidal ideas and so on and so forth. So you have to extend your limits in a certain way and your practice to adolescent psychiatry, which I do. Okay. So as I say, you know, the access is an issue. So virtual care is useful for this kind of thing. And they want also to access mental health care through innovative solutions, complementing in-person mental health care delivery through free online support resources that are available. And I'm going to show you resources which are financed by the government of Ontario, Ministry of Health and Long-Term Care. So they want the OTN or the virtual care to link better primary care and specialized care, which is another problem that we have. You know, sometimes specialists are not available. So this is why, as a psychiatrist, I more or less I have a caseload, but I work a lot with family doctors. And to increase the capacity of providers offering specialized care, optimizing the provincial access network, as we say, streamlining access to integrated virtual care solutions, and facilitating simpler workflows for clinicians and administrators that standardize virtual care. So they try to, for us, doctors, to get the best solution. So I'm going to give you 3 examples of virtual programs for Ontarians, and I show you the map of Ontario. Do you have a pointer? Yeah? Okay, so, sorry. Where's I have it? Oh, yeah, sure. So I'm here, Ottawa, Toronto is here, and where I go is this area. Cochrane, and Moosonee is this on Hudson Bay or James Bay. So to go there, there's only one railroad. So as I say, it's not easy to travel, but it's doable, especially by the climate also. As we know, we might have some snowstorms in April, which is usual. It makes your mood very sad, you know, because we are still in winter to May 15, roughly. So this is something which also it's important to remember. And I'm trying to practice or to recommend your light therapy, something that you might need here, but we don't have. We do lack sunshine and light in the wintertime. So who are this program? The first one, Ontario BounceBack. So this is a free, it's available on your computers. It's a free program to be launched by the CMHA, Canadian Mental Health Association. It's an online solution enable adults and youth, and I would underline youth, 15 plus, to learn skills through videos, telephone coaching, help manage symptoms or mild to moderate depression and anxiety. And I'm prescribing or telling the patient to go to BounceBack more and more. Why? Because first of all, to get a psychologist, psychotherapist in Ontario, it costs about $200 an hour. So some people have no money, they don't pay. So it's free, this one. And also it's anonymous. You don't have to tell your name, your address, your age. So no, and it's quite informative. So they can learn any time of the day or night. And we know that psychotic patients live during the night, not during the day. Now, it may not be so helpful for psychotic patients, but definitely for anxious and depressed patients that I see more or less sent by the family doctors, it helps. So they have workbooks, and sometimes I ask, did you do the workbooks? You know, they don't like duties, they don't like to work. Homework, they don't like it. So I say, okay, don't worry. You can continue to look at it. And what is important, if you need to speak with somebody, you can speak with somebody, which I think it's very important. Some people want to tell, you know, what's going on, and it's available 24/7, which is quite good. So This BounceBack is available and multiple languages, not only French and English, but also Mandarin, Arabic, many other languages, definitely. And it is free for Ontarians, but it's free for everybody. But if you want to register, you want to talk to somebody, you need to be a resident of Ontario. And it's funding by the government. The other one, which is also very important, and by the way, all these three examples are valid. There are lots of research in this kind of application. And also how can I say? It's sponsored by the government of Ontario Ministry of Health and Long-Term Care, so it's quite good. So the big white wall, what is important on this one is, especially for adolescents, you can have peer support. And peer support is very important, so that means you can talk to another adolescent. Okay, I'm going to be faster. So CBT delivered over the internet for depressive symptoms, there are validation studies. And what is important is what I did put in red. So it has a medium effect. What is important, internet CBT has a large sustained effect in maintaining the reduction of depression symptoms in follow-up measures, because many programs, they don't have, but this one works for follow-up measures. And it could be good for treatment, treatment modality for those unable or unwilling to access face-to-face therapy, because there are a lot of people who don't like to see the therapy straight away. And the last one is ability CBT. It's like an internet-based cognitive behavioral therapy program, access for any device, anytime, same thing. And it works the same way as CBT, but virtually. And I would go faster. Can smartphone mental health intervention can reduce symptoms of anxiety? And I'm sorry for the busy slide, but yes, it works. So I would look at the problems. First of all, there are some glitches. Lack of privacy. You know, you have the first question I ask when I see a patient on teleconsultation, are you alone? Is your door closed? This is important to ask, you know. And I say, yeah, I'm alone. There's no microphone in the walls, you know. Don't worry, my door is closed, you know. The other important thing is, where are you? You know, some people are in their cars. They don't want their wife to know what is going on, or parents and so on. And is it the right time? Because obviously there are confusion about time, and that makes a bit difficult, because my day is timed by almost by the minute, so one patient after the other. Now you have a technical issues, freezing image, then you have to restart. No fading sounds, it happens a lot. And sometimes, fortunately enough, they have a cell phone, most of us, so treating a patient, so we can talk over the phone. I can see the image and then I talk on the phone. So you have to be patient and you have to be inventive. You know, you want to keep the link with the patient while you are in the consultation. And unfortunately, many patients have no internet or low-speed internet, so it works not. It doesn't work. So I would say, if you want to launch a program like this for the whole state or region, it's better for to equip, you know, local agencies, local community centers to have an internet which works. Now, we did a study on the consequences of psychiatric care of COVID and the access of mental health to mental health. So I'm just going to talk a bit about the second question, which is the opinions of patients on distance communication during the closure of our premises. We did ask about our patients about what is the impact of the COVID and what do they think about the teleconsultation. And what they said mainly, so that's the part two that I'm going to talk mainly, and the patients were the patients that we have at Montfort Hospital, the outpatient clinic. Isolation to the pandemic was a life-changing experience for the patients. Lockdown, confinement was the public health measure which the greatest impact on people's life. Higher alcohol intake, higher food consumptions. And in fact, I saw live patients after 2 years, And I realized they gain weight because you don't ask on teleconsultation, you don't ask, can you go a bit further that I can see you how you look like, especially women. I'm going to ask, why do you think I will gain weight anyway? It's a whole other issue that I'm not going to talk about it, but this is important. No need for an emergency medical services. So they don't show up at the emergency. Now, TLF perception during the pandemic. So what the patient said, the advantage is good solution, no need of displacement, travel, social distancing and so on, that's fine. Challenges, technical issues, as I said before, comparing means of communication, video consultation, a better option than phone consultation, obviously. And the same level of comfort for the patients for video or phone consultation than in person, most of them. We were asking 40 patients, 30 were women, 29 women and 11 men on this in-depth survey regarding issues and how they feel about the teleconsultation. So the most important aspect would be the technical issues, which I think is still not completely resolved. That needs more time and more techniques to be much, and we are not allowed to use WhatsApp because I use WhatsApp for private and it's so easy. But because of the College of Physicians said, no, you use OTN, okay? What can I say? I have to watch out, practice is very, very tight. Anyway, so again, the result, there was no loss by using teleconsultation, etc. We kept most of our patients. And by the way, I'm also doing a study on no-shows because we have a lot of patients don't show up. It costs us a lot of money in the hospital. And I just saw that during the pandemic and during the teleconsultation, the no-shows are much less. So that's very important to think about it. They were grateful about the teleconsultation because we kept the link with them, but there were lack of information to know where to go or to receive help in the community, and they would like to have a website. So this is another thing that we need to do more information about what we do and how we can access and so on and so on. For some hospitals in Ottawa, they have the waiting list time. So if you are booked with a specialist, you know when you are going to see the specialist. Some colleagues also would do. I have a colleague of mine who 100% of his practice teleconsultation, but he told me that a patient can book himself or herself on his agenda. So no more secretary, no more hassles. Just book yourself for this doctor. That's quite interesting. So I guess, and this is kind of my conclusion because I see that you look at your watch. I give this is the conclusion of my talk and what the patients say. Teleconsultation for the patient can really matter. Mental health care providers must be patient and listen. And you have to be, I think you have to be more and more, how can I say, knowledgeable about the technique, and I'm not, which is a big problem in a certain way. You know how the internet works and how this platform works. So they wanted to say also that you need to remind them, daytime and of appointment, and I think it's possible through the electronic matter means that you could remind the patient the time where he or she has to show up. And I guess this is all. Thank you, merci, shukran. And this is almost spring, and I think this is the spring of virtual telepsychiatry. Thank you.